Localization of CNS, especially when there is a stroke. For that we should know what is the importance of history taking in CNS, how to localize and how to find out the etiology. Localization is starting from cortex, internal capsule, midbrain, medulla, pons, spinal cord and others, muscles, NMJ and nerves. With the presentation, so always when there is weakness, you always suspect lesion in the brain. In brain, how can you say it is cortex, internal capsule, midbrain or brainstem or cerebellum? There will be specific clues. If it is etiology, you can see the etiology, various etiology. If it is acute onset, it is almost vascular, except it can be trauma. Otherwise, acute insults can never be others. Others are demyelination, degeneration, space occupying lesions, which is not seen as an acute presentation, except in a few demyelination, you can get acute to subacute deficits. Long tracts involved in multiple sclerosis, you can get pyramidal deficits. The picture will be different. Now, if it is a vascular involvement, you have to find out whether it is infarct, hemorrhage or what is the vascular territory involved. Anticirculation and postcirculation. This is also in anticirculation stroke always has a good prognosis compared to postcirculation stroke, unless rather the stem of the internal carotid is involved or M1 segment of multiple MCA is involved. Otherwise, anticirculation has a good prognosis. Postcirculation usually is tough to treat with prognosis poor than the anticirculation stroke. We will learn how to identify cortex, whether it is brainstem or cerebellum or internal capsule. We start with a few learning points, simple scenarios. A 46-year-old male, diabetic for 7 years, left-sided sudden onset weakness. Left upper limb and lower limb is involved. There is urinary incontinence, left facial palsy. Now, cortex, coming to cortex. When cortex is involved, it will be focal deficits. Face and upper limb is involved or only the lower limb is involved, because fibers are distributed over frontal and parietal lobes. With cortex, there will be cortical irritation producing seizures and higher mental functions will be affected. So, cortex should have focal lesions, focal deficits, speech disturbances, higher mental function disturbances and history of seizures. This is what is important of cortex. When upper limb and lower limb is involved, a dense hemiplegia or hemiparesis, it is almost always internal capsule or below. Now, how to say it is internal capsule or brainstem? Nothing special. Brainstem means there will be crossed hemiplegia. Crossed means hemiplegia on one side, contralateral hemiplegia and ipsilateral cranial nerve. Same side, cranial nerve will be affected. If it is midbrain, third and fourth, pons 5, 6, 7, 8, medulla 9, 10, 11, 12. Ipsilateral cranial nerve, contralateral hemiplegia, that is crossed hemiplegia, that is brainstem. Very easy. Now, this patient has left-sided weakness and left facial palsy, both facial palsy. I told when cranial nerve is affected, it should be one cranial nerve, opposite side hemiplegia. There is an exception, that is, we all know, the lower part of the face, facial nerve supplying the lower half of the face has unilateral representation only from the opposite side. Upper motor neuron, that is upper motor neuron facial palsy. All others, upper motor neuron, supranuclear representation for all other cranial nerves comes from both sides. That is why there is no upper motor neuron palsy for other cranial nerves, except in rare instances there can be 12th nerve also, there can be Ullmann palsy. There is a same side left facial, that means the when facial and hemiplegia on the same side, that means contralateral internal capsule is affected. Because it is human lesion, it will be thoroughly examined, only the lower half is involved, upper part, wrinkling of forehead and closure of eyelids is not affected, because upper part receives representation from both sides. Urine incontinence. Why there should be urine incontinence? Paracentral lobule. Paracentral lobule in frontal lobe. Paracentral lobe, there can be spastic bladder in involvement of paracentral lobule. Frequent small urination. Urine incontinence doesn't suggest it is cord involvement. There is control in the pons and the frontal lobe. Pontine micturition center. And frontal lobe has paracentral lobule for evacuation. So, urine incontinence is also feature when there is frontal lobe involvement. So, this patient, there is left-sided facial palsy, left-sided full weakness along with urine incontinence. When you cannot localize to a single area, this urine incontinence cannot be explained by internal capsule. So, this urine incontinence is probably due to paracentral lobe involvement of the frontal lobe. If we examine speech, the patient may have speech difficulty.